Hello and welcome to our Cardiology module where we will be discussing aortic dissection. By the end of this module, you should be able to define aortic dissection, understand the causes and pathophysiology of this condition, outline the classifications used in clinical practice, diagnose aortic dissection based on history, physical examination, and investigations done, formulate management plans, outline the complications of aortic dissection, and finally, understand the prognosis of aortic dissection and how this is applied in clinical practice. Let's get started. So what is an aortic dissection? The term dissection comes from the Latin term dissecare, which means to cut into pieces. Aortic dissection is defined as a separation of the layers within the aortic walls. Before we learn the pathophysiology of aortic dissection, let us quickly revise the anatomy and physiology of blood flow through the aorta. This is a simple illustration of the anatomy of an aorta. The aorta is the largest artery in the body. The heart pumps fresh oxygenated blood through the aorta to deliver oxygen and nutrients to all the organs and tissues. The aorta is divided into two main sections, the thoracic aorta and the abdominal aorta. The thoracic aorta has four parts: the aortic root, ascending aorta, aortic arch, and the descending aorta. Let's now zoom in to see the layers that make up the aortic wall. The wall of the aorta is composed of three layers, which are the intima, media, and adventitia. The intima, the innermost layer, is thin, delicate, lined by endothelium and easily traumatized. The media, which is the middle layer, is responsible for imparting strength to the aorta and consists of intertwining sheets of elastic tissue. The arrangement of these sheets in a spiral provides the aorta with its maximum allowable tensile strength. The outermost layer of the aorta is the adventitia. This largely consists of collagen. The blood vessels which supply the aortic wall and bundles of nerve fibers which are involved in the production of pain lie within this layer. Causes of aortic dissection. Aortic dissection can be caused by existing conditions that make the aortic wall susceptible to an injury, for example, weakened aortic wall, which is seen in Marfan syndrome, Ehlers-Danlos syndrome, Noonan syndrome, osteogenesis imperfecta, aneurysms, and coarctation of the aorta. Aortic dissection can also be due to acquired conditions that increase shear pressure within the blood vessels, which in turn increases the risk of injury to the blood vessel. Examples of this are hypertension, pregnancy, which leads to increased circulating blood volume, iatrogenic, and syphilitic aneurysm. Pathophysiology of aortic dissection. The intimal layer of the aorta is thin and vulnerable to shearing effect. High blood pressure, or in the presence of a weakened aortic wall, shear stress within the aortic wall caused by the blood flow can lead to the tear of the intimal layer of the aorta, causing an aortic dissection. With damage to the intimal layer, blood moves through the break in the intima, separating it from the media, causing bleeding inside the wall of the aorta. The area where blood collects between the tunica intima and media is called the false lumen, whereas the area which is contained within the intimal layer is called the true lumen. An aortic dissection may be classified based on its location, whether it involves the ascending aorta, descending aorta, or both, or the duration of symptoms. If symptoms have lasted less than 2 weeks, it is an acute dissection and has a high fatality rate, hence requiring urgent medical attention. If symptoms have occurred for more than 2 weeks, the dissection is most likely chronic and regular monitoring is required, anticipating progression. The classification systems used for aortic dissection are the Stanford and the DeBakey systems. In the Stanford system, aortic dissection in the ascending aorta is called a type A dissection. Conversely, dissection involving the descending aorta is known as type B dissection. As for the other system, DeBakey et al. Classified aortic dissection into 3 types, which are as follows. The type 1, where the intimal tear occurs in the ascending and descending aorta. Type 2, which involves only the ascending aorta. And type 3, which involves only the descending aorta. These classification systems assist in delineating the mode of treatment, which could be medical therapy or treated surgically. Now let's dive into the more interesting aspect of this module, which is how to come to a diagnosis of aortic dissection. Diagnosis of aortic dissection needs to be rapid and accurate. In stable patients, a detailed history should be taken to assess symptoms. Symptoms assessment should include the onset of symptoms, if pain, the type, site, duration, and radiation of pain. Evaluate the risk factors such as hypertension history, congenital heart conditions like coarctation of aorta, genetic conditions like Marfan syndrome and Ehlers-Danlos syndrome, and not forgetting family history of aortic dissection. A focused clinical examination is important as this is a rapidly deteriorating condition. Signs to look for include hypertension, which may result from a catecholamine surge or underlying hypertension, hypotension, which may be the result of excessive vagal tone, cardiac tamponade, or hypovolemia from rupture of the dissection, an interarm blood pressure differential greater than 20 mm mercury, signs of aortic regurgitation, which include bounding pulses, white pulse pressure, and diastolic murmurs, signs of congestive heart failure, which are dyspnea, orthopnea, bibasilar crepitations, and elevated jugular venous pressure, signs of cardiac tamponade, such as muffled heart sounds, hypotension, pulsus paradoxus, and jugular venous distension, signs of superior vena cava syndrome, physical signs of Horner's syndrome, and physical signs of hemothorax. Imaging modalities are particularly important in establishing a diagnosis. These techniques include a chest radiograph, echocardiography, emergency CT angiography, magnetic resonance imaging, and aortography. Chest radiography. It is not the definitive imaging study for aortic dissection, but it should be performed as the initial imaging technique while awaiting for a more definitive modality. Classically, a widening mediastinum is observed. An abnormal aortic contour is also observed, and this is known as obliteration of the aortic knob. Echocardiography. This is an important imaging modality for detecting aortic dissection. It is also used to diagnose cardiac tamponade and aortic regurgitation. It is relatively quick to perform and non-invasive. The main drawback of this imaging is its strong dependence on operator experience. In this echocardiogram image, you are able to see an intimal flap within the aortic wall at the level of the aortic valve. CT angiography or CTA is recommended as the definitive test in most patients with suspicion of aortic dissection. CTA provides detailed anatomic definition of the dissection as well as information on plaque formation. Here, one is able to visualize the true lumen and the false lumen formed in an aortic dissection. Magnetic resonance imaging or MRI. This technique is the gold standard for detection and assessment. It has a high sensitivity and specificity of up to 98% respectively. It is able to create a three-dimensional reconstruction and determine the intimal tear location, extent of the dissection, and quantify the level of aortic insufficiency. It is non-invasive and no iodinated contrast is required. Aortography. Aortography has been the diagnostic criterion standard study for aortic dissection, but it is difficult to perform in patients with hemorrhage, shock, or cardiac tamponade. Aortography provides visualization of the true and false lumens, intimal flaps, aortic regurgitation, and coronary arteries with the aid of an X-ray contrast agent administered into the aorta. This image shows the extravasation of blood out of the aortic wall, causing a bulge over the descending part of the aorta, and this is known as the aortic knob being obliterated. Complications. Complications are diverse and numerous. System-related complications include the following: cardiovascular, such as acute aortic regurgitation, pericardial tamponade, myocardial ischemia, hypotension, and shock. Neurologic complications due to carotid artery obstruction can lead to an ischemic cerebrovascular accident. Respiratory complications such as pulmonary edema, secondary to acute heart failure, and compression syndrome, for example, superior vena cava compression syndrome. Treatment of aortic dissection. Here again, we look at the classification system discussed earlier. Emergency surgical correction is the preferred treatment for Stanford type A or DeBakey type 1 and 2 ascending aortic dissection. It is also preferred for complicated Stanford type B or DeBakey type 3. Medical management remains the treatment of choice for descending aortic dissections unless they are leaking or ruptured. Medical management with antihypertensive therapy including beta blockers is the treatment of choice for acute and stable chronic aortic dissections. With the use of intravenous beta blockers, the treatment is aimed at decreasing the blood pressure and the shearing forces of myocardial contractility in order to decrease the intimal tear and propagation of the dissection. Prognosis of aortic dissection. 40% of all patients die suddenly with aortic dissection. This highlights the importance of rapid diagnosis and referral for surgical repair or medical treatment if indicated. The surgery itself is extremely high risk with a mortality of 5 to 20%. There are risk factors which affect the prognosis post-operatively. Increased pre-operative evaluation time, because the longer you take to diagnose, the more severe the disease progresses. Older age population has shown poorer prognosis, possibly due to the existing a much weaker aortic wall because of cystic medial degeneration, which leads to slower healing. Cardiac tamponade is associated with fatal outcomes due to the hemodynamic instability it renders. Pre-existing heart pathology like myocardial infarction and coronary artery disease affects prognosis of patients post-operatively as recovery function of the heart is slowed down due to myocardial hypoperfusion. Acute kidney injury. Studies have outlined the predictive role of pre-operative low urine output and rise in creatinine levels in the outcome post-surgery. Most cases of acute kidney injury in type A dissection result from medullary ischemia and reperfusion injuries. Let's recap. The take-home messages from this module are: Acute aortic dissections are fatal and requires immediate medical attention. The tear of the intimal layer of the aorta forces blood into the medial layer, forming a double barrel aorta which encompasses a true lumen and false lumen. Aortic dissection is classified based on its location and duration of symptoms. MRI is the gold standard imaging technique to diagnose and establish the extent and severity of complications related to aortic dissection. Prompt control of blood pressure using intravenous beta blocker is the cornerstone of management of acute aortic dissection. Surgical intervention is required for Stanford type A and complicated Stanford type B aortic dissections. Mortality rates for aortic dissections are high, and this highlights the importance of rapid detection and referral for surgical repair. We have now come to the end of this cardiology module. Thank you.